All right, so in this talk, we're going to be talking about endovascular therapy for large vessel occlusion, acute ischemic stroke, the new shiny toy in stroke care. For those of you who don't know me, my name is Salim Razai. I'm a community ER physician down in San Antonio, Texas. I have one financial disclosure that I need to tell you. I am a consultant for Vapotherm, which is a high-flow nasal cannula company. There's nothing I'll be talking about in this lecture that has anything to do with this, but just want to be transparent. And the second thing is I am the creator and founder of a website called Rebel EM. And I promise at the end of this talk, because we're going to be going through quite a few references, I'll have some QR codes for you that give you those references. So let's start with what's the evidence for endovascular therapy for acute ischemic stroke. And the story starts back in 2013. So there were 3 trials that were done, and basically these were stroke patients that got randomized to endovascular therapy plus usual care versus usual care alone. And the outcome of interest was a good neurologic outcome. And you can see all 3 of these, IMS3, Mr. Rescue, and Synthesis, were all essentially negative trials. Now, there's a lot of reasons that probably occurred. Number one is anytime you have a new technology, you have to learn that technology and how to use it. And so the retriever devices they were using were these coils that they shoved up into the clot and sucked out the clot. And probably in that process, they were showering emboli. Doesn't really sound like a good idea. Obviously, in subsequent studies, they modified and learned better how to use those retrievers. The second issue is that a lot of these patients did not get any perfusion imaging. They were just doing anatomic studies looking for a large vessel occlusion, but we had no idea if there was already a large infarct core or if there was any functional brain left. And so that was probably the reason a lot of these were negative. The big year was 2015, and the first positive trial on this was Mr. Clean. Now, this is the largest randomized clinical trial that was positive for this endovascular therapy. It was 500 patients. And again, same randomization, endovascular therapy plus usual care versus usual care alone. And the outcome of interest, good neurologic outcome. So what was the number needed to treat for that? 7. So pretty impressive number. I want you to remember this number because we'll come back to that when we're talking about some of the issues. Now, quickly after Mr. Clean got published, there were 4 other trials that were recruiting patients for the same exact thing. And they all stopped recruiting because they felt like it was unethical to continue to randomize patients after the publication of Mr. Clean. Now, if we look at the number needed to treat for each of these, you can see that they're fairly similar, but on average, they are smaller than Mr. Clean, and we'll come back to that. So remember that number needed to treat of 7. 2016, we get 2 more studies. We get Thrace and we get therapy. And what we see is that Thrace was positive, which by the way is the second largest randomized clinical trial that was positive with just over 400 patients. You can see that number needed to treat of 9. And therapy was the first trial that was actually negative after those initial 3. So I told you I want you to remember that number needed to treat of 7 for Mr. Clean, the largest, and Thrace, the second largest, number needed to treat of 9. 2017, now we're starting to push the envelope. What if we look at patients who have strokes that go out to 24 hours? Well, looks like endovascular therapy works for those patients too. Number needed to treat of 3. So pretty impressive going all the way out to 24 hours. And then 2018 is when it all changed. So Diffuse 3 went out to 18 hours. Again, same outcome. They had a number needed to treat of 4. So now you have 2 randomized clinical trials, 2 of them that go out to 18 hours, and then 1 that goes out to 24 hours. And this is where it all kind of changed. And now we're completely overhauling our neurosystems to basically catch these patients because this has been reproduced over and over again. This table is a little bit busy, but I've highlighted it to make it simple for you. You can see that the first 3 trials were negative. Of the remaining 9 trials, this is reproduced. 8 out of the 9 had positive outcomes. So this is better than the evidence we have for thrombolysis and stroke. So I would say that I believe this outcome because we see so many green here. So before we get all excited, let's talk about some of the issues with these trials. So most of these, if not all of them, minus Mr. Clean, were stopped early. And why is that a problem? So anytime you stop a trial early, you tend to overestimate the benefit. There's no regression to the mean. So here's all the positive trials, okay? And Mr. Clean is 500 patients. Thrace is 414 patients. All the other trials are significantly smaller. And you can see that that number needed to treat of 7 to 9 is the numbers I told you to remember, is most likely closer to what the benefit actually is. It doesn't mean the other studies aren't correct. It's probably not number needed to treat of 2 or 3 though. The second issue is funding. Every single one of these studies was funded by the maker of the devices or of some other medication that was being used. And I'm not saying that that negates the outcomes that we have, because we see this consistently reproduced over and over again. But I want to remind you of a tragedy we had in medicine from a company called Roche. And the medication I'm talking about is Tamiflu. And so they kind of funded all the studies and didn't really, they weren't transparent with all the data and said, oh, see, if you give it early, there's all this benefit. Once we finally got our hands on the data, it turns out that there's probably a lot of side effects that we need to consider, and maybe the benefit is not as good as the harms that we're potentially causing. Now, I'm not saying that's the case with endovascular therapy, but just something to think about when you see funded studies. Just be a little bit skeptical. I think this is probably the biggest issue with these trials, is that they're all non-blinded. How do you blind endovascular therapy versus usual care? It's not the fault of the authors. It'd be kind of hard to do, but let's take a moment and talk about this. You have one doctor who believes in endovascular therapy. You have another doctor who doesn't believe in endovascular therapy. Now let's take a subjective outcome like the modified Rankin score from 0 to 6. 0 being completely normal neurologic outcome, 6 being dead. Now, the numbers 2 and 3 are interesting because you have a good neuro outcome with mild deficits for 2. You have a good neuro outcome with moderate deficits for 3. And this is where unblinding and bias kind of start playing in. So let's say I'm the doctor that's evaluating these patients, and the ones that got endovascular therapy, and I believe in endovascular therapy, maybe I'm going to say that their modified Rankin score was a little bit lower. Or I'm the doctor that doesn't believe in it, and so maybe I'm going to say their modified Rankin score is a little bit worse. So you can see how this is not an exact science, and anytime you have unblinding with a subjective outcome, this can really kind of fudge with what the outcomes are. This is going to be a very limited patient population. I have the number 770. Why do I have the number 770 there? Because this is the number of patients you would have to screen with stroke till you find a large vessel occlusion that would qualify for endovascular therapy. Now, all the trials, unfortunately, don't tell us how many stroke patients they screened, but the ones that did, if you add up their numbers, 0.8 to 17.3 patients per center per year. So we've overhauled complete systems, but this is going to be a very specific patient population. And I worry that we're going to get some indication creep. So you spend all this money for an interventional radiologist or a neurologist or neurosurgeon to be on call. You buy all these devices and you start only having 1 to 15 patients a year. You can see how they will start trying to use that for other indications that have not been studied. Who qualifies for endovascular therapy? It's really quite simple. It's anterior cerebral artery, the intracranial internal cerebral artery, and then the proximal middle cerebral artery. So what I've highlighted here for you and grayed out in the back. So this is going to be your M1 and your M2 segment on your middle cerebral artery. How do we identify these patients? I'm not really a big fan of the NIHSS score. I actually like this score called the VAN score. It's simple and it just makes anatomic sense, and I'm going to explain it to you. So what does VAN stand for? Vision, aphasia, neglect. So essentially what this score is, the patient has weakness on one side of their body, and any one of these things, it's a large vessel occlusion until proven otherwise. So let's talk about this. You guys didn't think the homunculus was going to make a comeback at a big international conference. Well, I'm bringing it back. Now, if you look at the light blue, this is going to be anterior cerebral artery. And if you look at the yellow, this is middle cerebral artery. So let's talk about the homunculus here. For your anterior cerebral artery, you can see that this is going to be lower extremity greater than upper extremity. And for your middle cerebral artery, you can see this is going to be upper extremity greater than lower extremity. And then you can see how it affects vision, aphasia, and neglect. It just happens to fit exactly the anatomy of the brain, and it just makes sense. And here you can see weakness. You get your anterior cerebral artery and your middle cerebral artery, and then vision, aphasia, neglect also gets that anterior cerebral artery. And you can also see why that intracranial internal carotid artery would also affect this. So the bottom line after going through all this is that in patients who have ischemic stroke less than 24 hours, and we find a large vessel occlusion, endovascular therapy has been reproduced over and over again. Yes, we've gotten better at doing this with perfusion-based imaging now, but this is the future of stroke care, especially in these patients. I promised you 2 QR codes. One is a study looking at the VAN score, and the other is the evidence for endovascular therapy. Thank you so much for inviting me to the conference, and I will be happy to answer any questions after this talk.